And especially those questions, there's when yellow pea pod marries a green pea pod and what organism will come, and then we all get lost. Okay. So I'll take you to this journey of genetic testing for cardiovascular health, insights into heart disease, diabetes, and obesity. So why this topic became important is because we have recently witnessed a surge of celebrity deaths, young deaths occurring in the country. Yes, we attribute it to myocardial infarction, but nothing beyond that we are able to do. And very recently, 1st of January 2025, this article came in Times of India. The bitter pill is that the healthcare providers themselves are the sufferers. So what good are we going to do for the society overall? I'll not go into the details of epidemiology of non-communicable diseases, but yes, they account for almost 60% of total deaths in the country. And just 2 weeks ago, there was a data that cancers have actually outcrossed and become the #1 killers in our country just 2 weeks ago. But overall, the cardiovascular disease burden in India is immense. Diabetes, we are almost the world's capital for diabetes, and so in obesity. A very good data came out that in just 5 years, 2015 to 21, there's almost a doubling effect across children, men and women as far as obesity occurrence is concerned. So, genetic predisposition in the Indian population. It began with the Human Genome Project started by United States, and then all nations became a part of it. We have genetic pool from Caucasians, Indians, Asians, Southeast Asians, and everybody. So on the right panel, it's a very busy panel. Yes, the genes have been mapped for diabetes, obesity, dyslipidemia, hypertension, smoking, unknown gene. In Icelanders, there is a gene which is there 10% in the genome. Any bad habits, anything you do, you are going to survive long. And Indians have it 0.1%. So there's something called gene X. So we have this genetic information with us, and now with the advent of artificial intelligence, we are able to generate what I'll be showing you in future slides. The gist of my talk lies in this slide. It's a very busy slide, but this article came in JACC in December 2024. Suppose an 18-year-old or 20-year-old gentleman who has genes of diabetes but has not the phenotype of diabetes and is going to walk into a diabetes clinic 30 years from now has 5 times higher chances of cardiovascular events. Versus a gentleman who is 45 years, 48 years old, 50 years old, who has already been coming for follow-up for 5 years because of diabetes, has 2.2% risk of having a MACE event. So just having diabetes in your genes, which is not yet manifested as a phenotype, is also a very important risk factor. So these are the key factors affecting heart diseases in terms of cardiomyopathy, cardiac arrhythmias, myocardial infarction, heart failure, hypertension, blood lipid disorders, atherosclerosis, and thrombotic disorders. Majority of these are either polygenic, means many genes are responsible, or monogenic, that is single gene is responsible. So in cardiology, we have mapped the genes, we have mapped the single nucleotide polypeptides or polymorphisms. We have also mapped how drugs would behave in certain individuals and which drugs to be given for which individual. A slide, just a brief. Majority of the audience today is diabetes, and I do think that you can treat your diabetes either as monogenic diabetes or type 2 diabetes. And in monogenic diabetes, neonatal diabetes and MODI. And if you can ask for a genome testing from us and you get a particular gene like KCNJ11 gene in your neonatal diabetes, then high dose sulfonylureas are enough, no need to go for insulin therapy. Similarly, if this is not there and you have another abnormality in terms of INS gene polymorphism, then insulin therapy is a treatment of choice. Similarly, in MODI, in HNF1 alpha gene polymorphism, low dose sulfonylureas would act well, whereas in a stable beta cell dysfunction, no treatment is required. And type 2 diabetes mellitus is definitely polygenic and it needs a detailed evaluation. Similarly, obesity is monogenic, polygenic, and you can offer precision medicine for your obese patients. So, how do you think genetic testing can transform healthcare in India? Early detection, definitely we can detect predisposition even before symptoms appear. We can help tailor medication choices and lifestyles. Family screening will identify family members, enabling more proactive care in the families, increase adherence to treatment, and planning for future generations to be disease-free. So as a genetic platform, the treatment or the testing offerings are in 4 formats. Polygenic risk score, which is basically a screening test. Variant analysis, where we analyze genes that run in families. Pharmacogenomics, the medicine or the art of detecting which medicine works well in which individual. And nutrigenomics is a branch which influences on nutrient metabolism of their dietary needs, allowing to have a personalized diet plan recommendations to support heart health. The technology that we use is whole genome sequencing and next generation sequencing. So next gen sequencing is something like for a PCR, which we used to do for COVID testing. So either testing is done in layers where you go more horizontal and get good amount of data, or you cut the genome into depth where you can go into the deep genetic format, and then the AI is able to generate the genes which are abnormal. So polygenic risk score is a screening test which quantifies contributing effects into a score and estimates whether the tested individual is at high risk of cardiovascular disease or not. It's not about identifying a disease, it's about assessing the risk. It gives an objective scoring to a particular phenotype that is going to come or has come or it may not come. So it provides a personalized estimate of disease risk by analyzing multiple genetic variants. It gives an objective score and you compare it to population average. So polygenic risk score or genetic testing in particular doesn't behave in terms of specificity, sensitivity, that is for the results to tell. But what it behaves is in terms of area under the curve. So suppose Indian population is going to be subjected to have 80% CAD. So whether you fit into how much above that 80% or below the 80% is what a polygenic risk score is. People with high PRF definitely benefit from early intervention. We can offer them personalized medicine and disease prevention. PRS does not diagnose disease, but it rather provides an estimate of the risk if the disease comes. The limitation, it may not capture all genetic factors because there is a lot of epigenetics which is going on, and it should be used in conjunction with clinical evaluation. This is a very beautiful slide which came in circulation. The predictive accuracy of clinical risk tools with addition of PRS. So for say ischemic stroke, atrial fibrillation, coronary artery disease, all the phenotypes, like we use Framingham risk score or whatever clinical scores, and if we add the score, the genetic derived polygenic risk score, and we go on to add, the predictive accuracy goes multifold. So for example, you are analyzing a 35-year-old gentleman for a health checkup who has come to your clinic, and on Framingham risk score, he comes into say 1% disease for coming 10 years. But you do a PRS for this gentleman, and if the disease score for coronary artery disease comes high, then definitely he is a candidate who needs more attention from all of us in his treatment care. I don't know whether this slide is seen from behind, but this data came in JAC in December 2024. What it says that any individual who is not yet diagnosed with acute coronary syndrome or chest pain or unstable angina or anything, and you do his PRS, and if he has a high PRS, he has a high chance of risk of plaque rupture. So very, very important data. Not only plaque rupture, even plaque progression is going to be very high in these particular individuals. So this forms a case for doing genetic evaluation for majority of us. The gene variant analysis I will show you in detail in the coming slides. But yes, monogenic disorders for hypertension, for heart diseases like familial hypercholesterolemia, hypertrophic cardiomyopathy, prolonged QT syndromes, atrial fibrillation, Marfan syndrome, Holt-Oram, dilated cardiomyopathy. So the cardiac diseases which run in families, you need to identify by monovariant gene analysis. Pharmacogenomics also I'll show you with examples, and nutrigenomics also I'll show you with examples. So this is the case one, high LDL cholesterol 275 and a family history of cardiac illnesses, and a pathologic variant in LDLR gene was found, and just switching from statins to PCSK9 gave a 50% reduction in LDL cholesterol. Similarly, this is the case of a diabetic female wherein she was not responding to routine metformins, and doing a pharmacogenomics and a detailed study switching to SGLT2 inhibitors gave HbA1c drop from 8.5% to 7% in a period of 3 months. So it's a basic 3 ml EDTA blood is sent to the laboratory, and the turnaround time for the test is 4 to 5 weeks. So this is how a typical Gene Sutra, that's a brand that I have formed, is known as Gene Sutra, and that's how a typical report looks like. And this is my own report which I am sharing to you. I was the first candidate for Gene Sutra. So my polygenic risk score, having given them a history that a 50-year-old man with known history of hypertension, family history of cardiac issues in both father and grandfather. So on this history, the polygenic risk score that came out was obesity high, type 2 diabetes population average, colorectal cancer population average, and coronary artery disease population average. The screening is offered for almost 22 diseases across cardiometabolic health, hereditary cancers, mental health, neurologic disorders, focus and energy disorders, and metabolic and dietary disorders, and miscellaneous conditions like rheumatoid arthritis, multiple sclerosis, asthma, Alzheimer's, and Parkinson's disease. The detailed offering of obesity for me says that I have a PRS of 0.97, which translates to an odds ratio of 1.7. So if in India the incidence is going to be say 30% for obesity, I am going to have 1.7 times more obesity or those genes for me which are responsible. For type 2 diabetes, I have a negative PRS of 0.28 and which translates to the risk being almost less than 30% than the population average for me. For CAD, my PRS is minus 0.78, which translates that the odds ratio for me is 23% less than the average population that I'll have CAD, though I have a strong family history. And what data we have seen previously, if I had a PRS of 1 or above 1 or a positive side, starting an aspirin would have been prudent for a patient, for a person like me, something of that sort. So pharmacogenomics, we almost test 75 odd drugs in the panel that we have, ranging from cardiac diseases to endocrinology molecules to psychotic molecules. And what came out for me that if at all I have to use amitriptyline, I need a 50% reduction in the dose. A normal dose would make me sleep more than rest of the patients. Statins, rest of the things are normal. One finding which came out is voriconazole will not work in me at all. And I think this is a report which my wife should have. Few years down the line, if I'm admitted under Akash Singh sir in an ICU setup, then they should know that this medicine won't act in me. So monogenic variants, as we had discussed, identify single disease or single gene disorders which run in families. And in our family, we have dilated cardiomyopathy, atrial septal defect. Not related to the phenotype, we have congenital deafness and thalassemia beta, which we should be careful for. The nutrigenomics panel tests regulation of eating. So my satiety response is very poor on a genetic basis. My fatty food preference and bitter taste means I'm going to be more attracted to these type of foods and which I should avoid. We also do macronutrient, micronutrient analysis. So for me, response to saturated fats and PUFA is bad, but response to MUFA is going to be good. So on an anecdotal basis, what my mother was feeding since childhood, groundnut oil was good, but my wife spending more money on sunflower oil is not good for me. And again, for weight management and maintenance, ability to maintain weight loss, these genes are very poor in me. We also have a panel for food intolerances for lactose intolerance, salt metabolism, gluten intolerance, and caffeine metabolism. And another last panel is allergies, food allergies, skin allergies, and nasal allergies. So after this detailed analysis of report, the important question that comes is what are the indications for genetic testing? So family history of CAD or sudden cardiac death, individuals with unhealthy lifestyle, all individuals with comorbidities like hypertension, diabetes, dyslipidemia, having recurrent diseases, individuals above 18 years of age, and especially if entering competitive sports. Because there's on-field deaths, recently I think we lost a cricketer on field. So we don't know whether it was long QT syndrome or it was MI or it was hypertrophic cardiomyopathy, and we can pick up these individuals. So the future of future of medicine is precision medicine. And without precision medicine, we'll be repeating the same mistakes, we'll be going into the same randomized trials format. And definitely the basis would be doing a genetic DNA testing to tailor the therapy for individuals and to offer them precision medicine. So we can offer directly gene therapy if we know that the pharmacs are not going to work. We can directly offer PCSK9 inhibitors for dyslipidemia patients if we know that the statin is not going to work. So what I spoke, I just want to show this one small slide. Can we have the volume please?
Density ज़्यादा है अगर जो जिनको डायबिटीज है तो उनको डबल डेंजर हो जाता है। आज के दिन में क्या हुआ है कि जस्ट टू एड्रेस इट, आज के दिन में साइंस इस जगह पहुंची है कि हम पूरी जीनोम सीक्वेंसिंग कर सकते हैं एक इंडिविजुअल की। उसमें ऑलरेडी आइडेंटिफाइड 3 तरीके के जीन्स है। एक है कार्डियक डिजीज का, उससे पता लग जाता है कि किसको ज्यादा प्रोपेंसिटी है, किसको नहीं है। अपनी लाइफ को आप टेलर कर सकते हो। डायबिटीज का भी ऐसा ही है। और थर्ड है कि कुछ कैंसर के जीन्स भी ऑलरेडी आइडेंटिफाई हो गए हैं, तो आपको ये भी पता लग सकता है कि क्या प्रोपेंसिटी है। क्योंकि अगर जो हम पहले कहते थे कि अगर जो आपके पेरेंट्स को हार्ट डिजीज है तो बच्चों को डबल चांस है, अगर जो पेरेंट्स को डायबिटीज है तो बच्चों को डबल चांस है। तो सारी जिंदगी यही सोचते रहो कि मेरे पेरेंट्स को था तो मुझे हार्ट अटैक होगा कि नहीं होगा। उसके लिए 3 चीजों को मिला के हम एक प्रिस्क्रिप्शन लिख सकते हैं इंडिविजुअल के लिए। जीनोम सीक्वेंसिंग, phenome is your body structure, your living habits, your stress levels, your where you live. जैसे pollution is a big factor in people's heart disease. उसके साथ और तीसरा हम जो डिजिटल मेजरमेंट करते हैं, जैसे स्ट्रेस टेस्ट किया या एको किया या ऑल दोस थिंग्स, इस तीनों को अगर जो हम एक एल्गोरिथम में डालते हैं, और ये ऑलरेडी हो रहा है, then we can write the health horoscope of an individual.
So with this, I conclude my talk. I think the 2 gentlemen were trying to fight Kamala Harris's genes, but they couldn't in India. Thank you so much.